Hello, friends. So today I'll be giving a brief overview on herpes simplex virus hepatitis in pregnancy. So we came across a very interesting case currently, and we are right now, as I'm speaking, this patient has recovered and it is in my ICU. So just I'll give you a profile of this case which came to our ICU and who got better because this is a very rare sort of a condition and until 2012, only 36 cases are published globally on this particular case, HSV hepatitis in pregnancy. Because one needs to really, really have a very high index of suspicion when you are contemplating this diagnosis. And we had a twin pregnancy lady, 28-year-old, who came with a fulminant liver, and she remarkably improved. And we have extubated her, and she's doing good. And we may be sending her to ward tomorrow. So, and we pondered about as to what are the key things that we should be aware of when we are dealing with such cases in pregnancy. So I wish to acknowledge Dr. Pratibha who helped me develop this content, and you have my YouTube QR code. You can scan it to watch these videos again. So when we talk about fulminant liver and more so suspecting HSV in pregnancy, it is very rare. So as I said, till 2012, only about 36 cases are reported globally. Reported means published globally. I'm sure many might have seen it. And the mortality in these is pretty much close to 90%. So that's the sort of mortality it carries. And we need to be aware that it occurs in predominantly third trimester. But in our patient who came at around 28 weeks, so she had this herpes simplex hepatitis. And this was first sort of reported by Thomas Henry Fluid in 1969. And this report was made from a fulminant uh, herpes that happened following a oral herpes infection. So this was a case, and this was in a male patient that he diagnosed this and he reported this. And when we talk about fulminant liver failure, if you look at the prevalence, it is around 2%. It's a very small percentage. And if you look the viral causes, so I'm talking about fulminant liver in pregnancy is around 2% is occurrence rate, and it is viral related, it is only about 1%. So it is pretty rare. And 62% of herpes liver infection happens in uh, sort of a obviously female population, and 76% of this happens during pregnancy. So what we need to be aware is there is some predilection in having this infection in pregnancy because 76% of this herpes liver tends to happen in pregnant ladies and immunosuppressed ladies. So the whole contention is whether pregnancy, although we all understand that it's a physiological, whether there is some immuno sort of a challenge that they are facing, whether could we call them as a immuno challenge is something that one needs to ponder about because 76% of the time the herpes liver tends to happen in pregnant ladies. So that is the why we are talking on it is because the mortality of this is very high. And this is very interesting because all the reported cases, only 33% were diagnosed when they were alive. It means antemortem diagnosis happened. So most of them were in retrospect recognized and identified as herpes, which means after the death, they have established the diagnosis. Only in a small group of patients, this fulminant liver due to herpes has been recognized and reported. So which means it's very rare. The reason I'm doing this sort of a narrative is for all our intensive care friends. If you have a pregnant lady with liver dysfunction, at least think of herpes because you can save the life. And I'll show you the data why we can save a life. Because if you do not start acecloprid for these patients, because in this patient, 28-year-old, we did all the workup. We did all the hepatitis workup was negative. Means hepatitis A, B, C, E, all were negative. Autoimmune was negative. So that is when one needs to have an index that in pregnancy, think of herpes. And we did Epstein Barr also, that also came intermediate, so on and so forth. So what is the pathogenesis of herpes infection? So for all our intensive care trainees, there are two herpes viruses, HSV1. HSV1 predominantly causes oral herpes, but it is the HSV2, which is a genital herpes. It predominantly causes genital herpes. And this has shown to have a greater intensity of causing fulminant liver. And HSV2 is postulated as something which tends to cause more severe ramifications like liver dysfunction or meningoencephalitis. And when we have to categorize herpes, they can occur as a primary infection, or they can occur as a secondary infection, or it can occur as a non-primary first episode. And as I've already made a mention, until 2012, only 32 cases of herpes fulminant liver have been reported, have been published. I'm sure people would have seen, not necessarily published, but reported cases are only 32. So the incubation period for herpes is only 4 days, but it can vary from 2 to 12 days. Our patient, who is a 28-year-old vicar, came as a referral from another hospital following worsening liver dysfunction, but she did have a prodrome of what appeared like oral herpes. She did have throat pain and she did have some oral ulcers, is what she said, but we couldn't identify any oral ulcers, but she had some pharyngitis. So we were thinking more in terms of Epstein-Barr virus that came as intermediate or negative. IgG was positive. So then herpes PCR came positive and we treated with acyclovir, and we'll talk about it. So why does this occur? So as you see, when our immune homeostasis is breached for whatever reason, so there is some sort of a homeostasis of our immune mechanism which has breached, that is when the viruses tend to affect an individual. So there has to be some sort of a immune challenge that a patient or an individual is threatened with when these barriers are breached by these viruses. And following the viral infection, there is impairment of these macrophages and there is impairment of the cytotoxic T cells. So there is impairment of these cellular mechanisms, and the liver dysfunction that tends to happen following impairment of this is shown to be due to delayed hypersensitivity. It is like a ATT-induced hepatitis. So something like a drug-induced, there is a immune mechanism mediated hypersensitivity that tends to happen, and there is dissemination of this virus systemically as well. But there predominantly it's a cellular-based and hypersensitivity-based immune sort of a disturbance or turbulence that leads to the liver dysfunction that causes severe hepatitis. And that's what our patient had. And as you see, the mortality, why we are talking about this, because mortality is as high as 90%. In the published reports, I'll show you some of the reports. The mortality is always more than 80% if untreated. So that is the sort of mortality that one would be dealing when you have a herpes associated liver dysfunction. So when you talk about clinical features, like any other viral infections, they will have a prodrome of fever, malaise, fatigue. But headache is something that has been put at 67% of them will have headache. And as I said, HSV2 can present with meningoencephalitis. They can be encephalopathic. And meningoencephalitis, 42% of them are caused by HSV2 and 12% of them are caused by HSV1. And recurrence has been shown to have occur in 1% of the individuals. And this recurrent benign sort of a meningoencephalitis is called as mollaret meningoencephalitis. So that is one variant caused by HSV, which is uh, referenced as a benign and recurrent sort of a meningoencephalitis. And when you talk about lymphadenopathies, 80% would have lymphadenopathies. So we did check for lymph nodes. We couldn't clinically palpate for our patient. They can have herpes pneumonitis and hepatitis. So our patient predominantly had a liver dysfunction going into fulminant liver. So that is another thing. And 67% of them can have urinary symptoms like dysuria. They have a painful mucus. So these are the some of the described symptomology in herpes sort of a infection. And of course, they would have blood parameters which are deranged. They can have thrombocytopenia. Our patient, of course, had thrombocytopenia, had leukopenia, and they can have secondary HLH. So our patient, 28-year-old pregnant, we had secondary HLH. We did give her steroids, and that was also like any other viral infections. Like we have tropical fevers causing secondary HLH, dengue causing HLH, or scrub typhus. So like any other viral, they can cause secondary HLH, and our patient also had secondary HLH which we treated. So these are some of the reported cases. So I just want you to focus on the ones marked in red. As I said, the female preponderance is more, 62% tend to happen. And as you see, 53% tend to happen in immunosuppressed individuals. So it is not an immunocompetent. This makes us wonder whether pregnancy is immunochallenge sort of a condition. And just look at the square box. Predominantly, what they had was coagulopathy and encephalopathy. Obviously, when there is a worsening liver dysfunction, they would have encephalopathy and they'll have blood dyscrasias, leukopenia, thrombocytopenia, and coagulopathy. Those are the predominant markers that you have. And of course, you will have ALT, which is a liver enzymes specific to liver, which will be very high. So these are the main sort of a characterization that you would see. And even if you see in the data, predominantly the fulminants were caused by type 2, which was 61.3%. And these are some of the two reported case series. So I just want you to focus on the red box. So with acyclovir, if you see, the mortality is 51% in both 50 to 55, but without treatment. If you have not recognized this as a herpes, fulminant herpes, and you're not treated with acyclovir, you can see the mortality sits at around 90%, 88% in one case series and 80%. So this is a sort of a mortality uh, burden that patients can have if you do not recognize this and if you do not treat up. Because I think our credit for our case goes to our gastroenterologist who sort of suspected that we had to rule out herpes. We sent out the herpes test and then we started off acyclovir. Possibly that helped her to recover and get better. So that is something that one needs to treat with acyclovir if you have an index of suspicion after sending the test, and you can always stop if it comes negative if there is no evident cause for fulminant liver. So how do we diagnose? There are different viral detection techniques. So viral culture, of course, all the listeners know it is not easy. So cultures to be taken from the swab lesion. Sensitivity has shown to be 70%, specificity is 100%, but this is lower in HSV2 virus. And I know culture turnaround time is longer, it takes much longer time. So this may not be the best possible tool to utilize to recognize HSV. The second one is immunofluorescence. So turnaround time is less than 4 hours. Sensitivity is 95%. But now the easiest tool that we all adopt, I'm sure most of my intensive friends would be doing is PCR-based techniques. So we did PCR for our pregnant lady to send for HSV DNA. You have to send for not antibodies. Antibodies are detected by immunofluorescence. We have to send PCR, which detects HSV DNA. And here, sensitivity and specificity is more than 95% when you adopt the PCR. So this is the easier tool, which is widely prevalent now in India. So we could utilize this as a tool because cultures takes longer time. Immunofluorescence, sometimes, as you say, the specificity may be an issue. So PCR DNA is the way to go because specificity and sensitivity both are more than 95%. And these are some of the histopathological findings that you will see with herpes, with various inclusion bodies and the inflammatory changes, so on and so forth. So that's about the diagnostic armamentarium. So when it comes to treatment, it is straightforward. You have to give acyclovir at 8 to 10 milligram per kg, 8 hourly for 7 to 10 days. If someone has herpes encephalitis, then obviously the duration of therapy has to be longer for 21 days. So when you are using acyclovir, bear in mind there can be resistance to acyclovir. So acyclovir basically gets phosphorylated in the presence of thymidine kinase to an active component. And it is the active component which is shown to be effective against the virus that you are treating. And sometimes there can be mutations in this thymidine kinase gene mutations that can confer resistance to acyclovir. This is something as an advanced thinker, if you have herpes and they're not responding, one may have to think about it. And you may have to contemplate second line drugs, which are tenofovir and foscarnet and plasma exchange. So we did do plasma exchange for our patient to support the liver. I'm sure all the listeners here would know when you're working a liver unit or a transplant unit, now plasma exchange has been considered as a bridge for safeguarding the liver. We did 3 cycles of plasma exchange for our patient because he had rapidly worsening liver dysfunction. And there are anecdotal reports, and this is a reference Holt et al. So that plasma exchange has some role in clearing or reducing the viral load and all the cytokines and so on and so forth. And it's a liver support sort of a modality that most of our centers are using, and we're using it fairly commonly now as a bridge for the liver transplant. So because we were contemplating if he continues to worsen that we should think of liver transplant also as the next step. So we did do plasma exchange 3 cycles for our patient and she did, and the liver functions actually remarkably started getting better, or at least it did not worsen once we initiated the flex for this patient. So again, just to show with acyclovir and no, and a group without acyclovir from the case series, if you compare, as you see, with acyclovir, the mean ALT and AST were little lesser as compared to the group without acyclovir. And even if you see the bilirubin and the platelets was little better. And as you see, the death was much lesser with acyclovir group as opposed to non-acyclovir group. Although you see the mean bilirubin tended to be higher in acyclovir group. So these are some of the case series data comparing the indices between the acyclovir group and the non-acyclovir group. So now one needs to know what are the risk factors in these patients that predict death, or the risk factors that tell you that you have to list for transplant, because we didn't start working up this patient for transplant because we started doing well with the plex that we started. But there are certain indices. Our patient had encephalopathy. So if someone has worsening encephalopathy, it is a clear indication that one should think of transplant or immunosuppression. So as I said, more than 75% of herpes liver happens in pregnant ladies. Whether pregnancy is a immunochallenging condition, I would leave my august audience to ponder about. Male patients have worse outcome, age more than 40 years, or someone who had thrombocytopenia and coagulopathy. Our patient did have thrombocytopenia and coagulopathy, but it did not worsen. It held on after we initiated flex. And if ALT is more than 5,000, for our patient, it touched around 5,000 and it started coming down. So that's what happened in our patient. So these are some of the indices which tell you that which portend poor prognosis and ominous signs. And these are the patients who have to be worked up for transplant, or someone who is not responded to acyclovir. So because our patient was initiated in acyclovir and was initiated on flex, and she gradually showed reduction in liver enzymes, and she started improving with her encephalopathy, platelets started improving, coagulopathy got better, she was extubated. So now coming to differential. So our whole thought process was whether it's fatty liver of pregnancy, because this, and whether it was health, because these are some of the conditions which tend to overlap with these infective conditions in pregnancy. I think this is the challenge that every listener who is listening to this talk would bear in mind, that you would have challenges whether you have to think of non-pregnant related or pregnancy related. So when you have a patient with liver dysfunction, you have to categorize them into two broad categories: whether it's an exacerbation of viral hepatitis or Budd-Chiari, because these are the two conditions which sort of tend to flare up during pregnancy. As I said, we did all the hepatitis workup, A, B, C, D, E, all that, everything was negative. Even we did Budd-Chiari workup with ultrasound Dopplers, it was negative. So Budd-Chiari can flare up during pregnancy. Obviously, then you have to think of, then we thought of herpes that came positive. But when you pregnancy related, there are pre-eclampsia, eclampsia. She was a 20 week, 25 weeks lady. So pre-eclampsia, eclampsia was not there. HELP is something that we had to rule out, and fatty liver of pregnancy is, of course, is something that one needs to keep it as a differential. And this was also not thought of, and liver rupture. So these are some of the differentials which are pregnancy related. So just to tell a narrative about our patient, she was a 18 weeker. So I kept telling 28. It's a 18-weeker pregnancy. So, and she had a circulate outside. So during the course of fulminant course, where her liver function started worsening and so on and so forth, she spontaneously aborted. So another important message is we worked as a team. Obstetric team was involved. And the whole concept is we did not terminate pregnancy because there was no evidence. Obstetricians were discussing amongst their group. So here, this was a patient, even they said if there's IUD happens, it will be aborted spontaneously, and we should not induce abortion in these patients, was the thought process from the obstetric team, which we value. And she spontaneously aborted in ICU, and the fetus was expelled. So the message is it has to be teamwork, and we had a good sort of a concurrence with regards to the thought process from our gastroenterology team, who in all these cases we do put them on flex, and they were the ones who suggested we should send herpes, and that was a very good pick, and herpes came positive, and she responded to acyclovir, she got better, now we have extubated her, she's done well, tomorrow we are shifting to ward. So this is a happy ending, but all my good friends, bear in mind the mortality is more than 90%. If you do Had we not treated her with acyclovir, suspecting herpes, possibly she may have deteriorated. That is the message for you. And although there was twin pregnancy, which was compounding this problem, we did not induce the labor. And that was a good decision because we looked into the evidence, and there is no reason why one should deliver the fetus. But you would induce, provided if it was health, provided it was fatty liver of pregnancy, provided it was eclampsia. That is when the obstetrician said we should induce. But if it is other condition, nature will take its call, was the understanding. So I think at the end of it, it was all the teamwork that really helped save the patient. And this is a good sort of a differential to keep in mind in any pregnant ladies, intensive care specialist see with a liver dysfunction, think of herpes. And if you pick it up, it's a great sort of a diagnosis and outcomes. You can influence a better outcome in these patients is the message that I wanted to give in this video. And for all my good friends, so this is a snippet we should remember. 28th July was the World Hepatitis Day, and Dr. Baruch Bloomberg, he was from a US, and he got 1976 Nobel laureate for identifying the hepatitis B virus, and subsequently the vaccine that was developed for hepatitis B virus. He had enormous role. He saved and is going to save millions of lives. So we need to remember this gentleman who discovered the hepatitis B virus and the vaccine thereafter. So I request all our listeners to attend our signature conference JIC that's happening from 18th to 20th October, and request all our listeners to submit valuable work to Journal of Acute Care. So you can visit my website and there's a QR code. You can just scan it to visit my YouTube to hear to all the lectures. So thank you. Thank you, Vanindol.